Good morning, everyone. My name is Dr. Melissa Simon, and I am a specialist in pediatric ophthalmology and adult strabismus. I'm joining you this morning from Providence, Rhode Island in the US. It's a warm and very humid summer day here. It's morning, and today I'm going to be talking about rectus muscle plications for strabismus surgery. This is my first cyber site lecture for Orbis, and it's a real honor to have the opportunity to talk with all of you today. I was able to participate in a lecture, in a tour, an Orbis week-long plane tour in Peru in 2012 when I was a resident. And I just think Orbis is the most amazing organization. And I'm really excited to be a part of this global community again. I saw the registrant questions beforehand, and I think I'm going to be able to answer almost all of your questions during the lecture today. So with that, let's begin. We're going to start with a poll question. And the first question is, have you ever performed a plication of an ocular rectus muscle? So we have 156 participants today. I've performed plications before. I'm curious how many of you have. So 40% of you have performed muscle plications before, 60% have not. And I'm hoping today that after talking, we'll have a chance to convince you that trying plications are a worthwhile endeavor. To plicate means to fold. And so that is essentially what we do in the plication surgery. We take the rectus muscle and we fold it. We can do this to a lateral rectus muscle, a medial rectus muscle, a superior rectus muscle, or inferior rectus muscle. I'm not going to be speaking about the obliques today, but we can plicate any rectus muscle. We fold the muscles once in a plication. It's not a multiple folding technique. And it's really just like a towel. That's what I tell my patients when I consent them for surgery in the office. And so just to demonstrate today, I made a model with a towel. This is a salad bowl from my kitchen, and I just drew the iris and the pupil on it. And here is a dish towel that I put some ciliary arteries on. And the idea of the surgery in a plication is to pass sutures through whatever distance we're plicating, and then attach that plication level to the original insertion so that none of the arteries are cut or interrupted. You can fold it this way with the excess muscle underneath, or you could fold it this way with the excess muscle on top. I'll show you some videos and we'll talk more about technique as we go. One thing we don't want to do in plications is get too fancy. We're not going to make anything complicated, no animal shapes when we're folding rectus muscles. So before we get into the meat of the lecture, I'd like to ask another poll question. Plication surgery, like resection surgery, works by A, tightening the rectus muscle, B, making the fibers of the muscle thicker and stronger, or C, triggering a biochemical reaction that grows more muscle fibers. And so 81% of you were correct. The surgery works by tightening the rectus muscle rather than by making the muscle fibers stronger. That's a popular misconception if you chose B. We often call it plications and resections strengthening procedures. But actually, what those surgeries are doing is creating a tether. And this illustration from Ken Wright's third edition textbook is really helpful at explaining how that tether works for a resection or a plication, either one. This muscle here is tightened. And when the eye moves in the direction of that tethered muscle, it has, still full swing. But the idea is when the eye looks away from the tethered muscle, there's a restriction. And that's how the surgery works to correct strabismus rather than actually changing the fibers and making the muscle stronger. And one of the most popular questions I received is, why do a plication? And are plications and resections interchangeable? In my experience, plications and resections are indeed interchangeable. And with one exception, if you need a biopsy of the muscle, then you have to do a resection because you have to get a piece of the muscle. But other than that, I think that plications work whenever you would otherwise do a resection. And there are data in the medical literature to support that. So on children, on adults of any age, horizontal, vertical rectus muscles, reoperations, new operations, adjustable sutures, we'll talk about all of this. I think that plications are a worthwhile endeavor as a substitute for a resection. The major reason is that it has been shown to reduce the risk of anterior segment ischemia. And so we all know that in order to do a resection or a recession of the muscle, these ciliary arteries that run over the top of the muscle have to be cut. And when we cut, 3 or more of those muscles, the risk of anterior segment ischemia is much higher. It's a rare complication of strabismus surgery, but it's a very bad one, and we want to avoid it whenever possible. And so it was first shown in animal models, and then later in humans, that the anterior segment circulation is indeed preserved with plication surgery. And so for me, that's the major reason to do the surgery. Why not preserve the circulation if the procedure works as well? And I'm going to show you techniques today so that it will. And then also, related to preserving the circulation is you leave open the opportunity for additional operations in the future. So, you may only be doing one muscle today, but 2 years from now, you may need to do 2 different muscles. And so if you've done a plication today, that opportunity remains if you have to do a recession later to interrupt those blood vessels without worrying as much about anterior segment ischemia. Other bonuses and advantages of a plication is the reduced risk of lost muscle. We know that with a resection, the risk of slipped or lost muscle is higher than with other surgeries like recession. And with plication, there isn't a risk of a lost muscle because we don't disinsert the muscle. We just fold it over itself. There is the possibility of early reversibility, but I'm going to talk about adjustables as a plan if you think you're going to want to reverse your procedure. You may not want to count on just undoing all of your work. There are reports in the medical literature that plications take less time. They cause less trauma, inflammation, and hemorrhage. And because of that, the recovery can be easier because the muscle is not being cut And we can still do vertical transpositions of our horizontal muscles or adjustable techniques, as I've mentioned, with plications. I'll show you that as well. And in my experience, the pain is much, much better for patients. I find that patients are so much more comfortable, even the first day after surgery compared to resections. The only contraindication, as I mentioned, is when a biopsy is needed. My sources are to the left here. So in this talk today, I'm going to talk about attaching the muscle to the sclera. And this is another illustration from Ken Wright's 3rd edition textbook. There was a question about muscle to muscle attachment. And there are doctors in our international community who have more experience with that. That's a tuck. And in my hands and in some of the papers I reviewed, muscle to muscle tucks for rectus muscles don't seem to work as well as plications, at least in this moment in time. So what I'm talking about today exclusively is muscle to sclera attachment. When I say plication, that's what I mean. So let's pause for a poll question. The best conjunctival incision for a rectus muscle plication is A, fornix incision, B, limbal incision, C, modified swan incision, or D, all are equally appropriate. And so we had a split, interesting. 42% of the audience said that the limbal incision was the best choice, and 40% said all are equally appropriate for the surgery. So I created a best answer, but actually I think you're both right. So I think D is true. All are equally appropriate, but also the limbal incision might be a little bit better than the others. I'll explain why. The limbal incision causes less interruption to anterior segment circulation. So if your main goal is to preserve anterior segment circulation, I'm sorry, not a limbal incision, a fornix incision. Sorry, so I misspoke. The limbal incision is a fine choice, but it's really, the answer is D, or a fornix incision. The fornix incision preserves the anterior segment circulation. So if your main goal is to preserve circulation as much as possible, I would recommend a standard fornix incision if the patient is an appropriate case and if the surgeon is comfortable with that type of incision, 7 millimeters to 8 millimeters from the limbus. However, all incisions are appropriate for plication surgery. And in a plication surgery, still the major ciliary vessels are being spared. It's important for a surgeon to use whatever incision he or she needs to be able to see the field properly, to do the work that is necessary, and to respect the tissue quality of the patient, depending on their age and their medical history. So I'd like to talk about my technique. And the first one I'm going to show you is based on Ken Wright's textbook, which I have been performing now for about 5 years. And then I'm going to show you another technique that I have recently started enjoying as well. So you start the procedure much like you're going to do a resection. And so you can see in this photograph, I have 2 green hooks in the muscle. You can use 2 Jamisons as well. It's important that the posterior hook doesn't pull too high up to the ceiling. We don't want to activate the superficial, we don't want to stretch the superficial muscle fibers more than the posterior muscle fibers. So you just kind of want to create like an even plane of the muscle, and then mark I usually mark however many millimeters I'm going to plicate. We'll talk about how many millimeters to choose in a little bit. And I take a marking pen and just mark the edge of my caliper and then I move the caliper across the muscle to make a nice clear line for myself. Then I proceed with partial thickness passes through the muscle, center to the edge. And I do not first do a lacking safety stitch. Many of you are used to doing a central full thickness bite here and tying it first in a resection surgery, and then doing your partial thickness passes. I would not recommend that in a plication surgery because it only adds more opportunity to strangle muscle tissue. And we're not worried about a lost or a slipped muscle in a plication. So it doesn't have a purpose. And so here I'm showing you the partial thickness passes. I try to do it just behind my line. Again, avoiding going in on a vessel. And then I go in the other direction and then I lock. And so to do my full thickness bites and lock, it's important to identify where the vessels are. And so you can see this very large one here. On the other side, there's a big ciliary vessel here. So I do my full thickness locking bites and try to avoid the ciliary arteries. You can see the knot here is just to the side of that. And you can ask an assistant or a technician in the OR with you to take a small hook or a non-toothed forceps or even a Q-tip to gently push the vessel toward the middle away from your knot while you're tying, if you're worried that you're going to incorporate the vessel and strangle it. And I try to get my locking bites right on that line of how many millimeters I've marked. Then once I've done that, the next step is passing the suture anterior to the insertion. Again, I want to avoid the ciliary vessels. So, I do my best. You're going to see some bleeding there. So it looks like I did get one of the more minor ones there, unfortunately, but I try to avoid them as much as possible. In front of the insertion, the sclera is relatively thick. And we need a very secure partial thickness scleral tunnel with our vicryl suture in order for that scleral tunnel to withstand the tension that's going to be put on it when it's time to pull and plicate the muscle. So you don't want a really thin, delicate tunnel. It has to be strong enough to withstand the pull that I'm about to show you in the next video. And I do use absorbable suture. You do not need to use permanent non-absorbable suture in this surgery. Over time, the excess muscle in the fold atrophies, but the muscle does scar to the sclera and the insertion in the spot you want it. And so in this video, we'll see that I'm tying this first as a 3-throw tie. I find the 3-throw very stable for my first throw. And then I pull up on the muscle to the ceiling and then in the plane of the eye toward the limbus for my second pull. And that folds the muscle. And you can see that happening now. I grab very close to the edge of the knot. I'm not pulling from way out by the forehead and the feet. I get as close to the knot as I can, and I pull up, and then I pull parallel, and then up, and then parallel. And I do that a few times. I try not to pull with a lot of force. I try to be as gentle as possible, but you can see here the muscle's folding really nicely, and you have a little bump here. You can take the hook out once the muscle starts to fold. I just left it in there to demonstrate in this video the fold. And so, after that, you can pull the hook out. And then I do a 1-1 after my 3 throw. I find that the 3 throw does not move. It's a very stable knot. And so then I do another one to lock it and a third one in case the vicryl unties. You don't need more than that. Actually, more knots than that will actually destabilize your knot. So 3-1-1 is plenty. In Ken Wright's book, he does 2-1-1, and you can do that for sure. It's a better approach for your tying if you're going to do an adjustable. A 3-1-1 you cannot adjust. It's going to be tight. But a 2-1-1 you can adjust. Just be aware if you do a 2-1-1, after your first throw with the 2, you need an assistant to take a non-tooth forceps or a needle driver to stabilize your first knot. Or when you throw your second knot, that first knot can get destabilized and you can end up with a weaker plication than you anticipated. So now I'd like to show you a second technique. And I just started doing this one. It is outlined in Dr. Irene Ludwig's textbook. And the chapter is written by Dr. Monte Del Monte from University of Michigan. And he advocated this technique. Well, first I'll show it to you and then I'll explain why he advocates it. So what we do in this technique, and this is me practicing his technique. So this is me practicing his techniques, or utilizing his techniques. So in this procedure, we set it up the same. I mark how much I'm plicating and I do my first partial thickness pass through the muscle, but then I actually go back through my original holes. So I go back through my hole that I exited the muscle here, and I exit the hole that I had entered the muscle in the center. And what that does is, in the second pass, it's more superficial, I'm just skimming underneath the ciliary arteries. And that way, I'm setting myself up to do a full thickness bite, again, through that same hole in the center of the muscle. And I've left this loop to lock it with. And you're going to see now, taking that original hole, and I'm going to pull it through that loop that I've created with that back and forth partial thickness pass. Usually we just do one partial thickness pass, but then we did a second back to set ourselves up to lock it. This knot will create an air hole if you just pull this vicryl here. So you have to stop yourself and pull back on the suture so that the loop is flush with your tissue. Once the loop is flush with your tissue, then you pull your vicryl all the way through to tighten the locking bite. And this technique, according to Dr. Del Monte, will give you more security with the ciliary vessels. Because the locking bite is underneath the muscle, it will not strangle or put pressure on the arteries that are on the surface. And because you're going back and forth through the muscle and then locking it from the center outwards, you can ensure that all of the muscle fibers will be incorporated in your plication without a central sag. And so in this case, when I did this procedure, then I passed the sutures anteriorly, the same anterior to the insertion, the same as I had demonstrated. You can do it with cross swords. I don't do it with cross swords, but you certainly can. In this case, I also did a vertical transposition of the horizontal muscle. So I did a half tendon width. So you can see here the muscle kind of folding over itself at this angle because of the vertical transposition. The patient did really well. So the next question that was very common in your pre-lecture questions was, is this procedure really reversible? I know it seems kind of like folklore that you can undo it. Oh, you can undo it. Sort of, maybe you can undo it. It depends if you reverse the plication soon enough after surgery. Some folks say you have to reverse the plication within the first 3 days, and cut the suture, completely remove it, take a hook and flatten the muscle out. Some people say you have up to a week to reverse the procedure, but certainly not longer than that. And if you're going to reverse the procedure, you need to make sure that the conjunctiva is still well opposed in your closure, because with all of that activity, you can stimulate scarring. If you anticipate wanting to undo the surgery, reverse the surgery, I recommend planning an adjustable technique. I think you'll have more control and probably a better outcome. And we'll talk about that. So there is a really good paper from the Journal of APOS by the group of ophthalmologists at UCLA who were early adopters of plications and do a lot of them. And they show a great series of cases of adjustable plications with a slip knot. So they do the original tooth row, and then they do a slip knot. They put in their anchoring suture in the sclera and adjust the patient after they wake up. There also are reports of using the noose technique, doing your first tooth row, and then using a noose around around those pull sutures. That's a possibility as well. It seems a little more complicated to me with a lot of suture involved, but you could do that also. I haven't done a plication on adjustables yet, so I don't have any of my own photos to show you today, but it has been done successfully. One tip that I noted by Dr. Del Monte is to incorporate 1 millimeter or 2 millimeters more than you want in the plication in order to have more room to adjust the patient after they wake up. So if you want to do a 6 millimeter plication, maybe plicate 7 or 8 millimeters so that you have more to adjust later. Another question that I wanted to address briefly was, what is Dr. Wright's mini plication? So this is a cool procedure that he does in the office under local anesthesia. And he does this for small horizontal or vertical deviations. And by small, we mean less than 9 prism diopters. So that's pretty small, surgically speaking. And in all cases, he advocates plicating the central portion of the muscle going 5 millimeters posterior. So we don't have a surgical dose table for this mini plication. We do have a surgical dose table for all other plications, and I'll talk about that. But for the mini plication, just 5 millimeters for all measurements, 6 prism diopters, 4 prism diopters, 9 prism diopters. They're all 5 millimeters posterior. And then you grab the central portion of the muscle and put a full thickness bite of your vicryl around that central tissue, avoiding the vessels that we want to spare, and tie it. And then plicate by doing your partial thickness passes through the sclera anterior to the insertion. And this plicates, as you can see in the drawing, just the central portion of the muscle. And so it's less effective than plicating the whole muscle all the way across, which is why it's called a mini plication. Okay, so are plications effective? This was a very popular question. Are they really as good as resections? I hope to convince you that the answer is yes. Um, so most published studies are case reviews. There aren't many randomized controlled trials where we compare resections to plications. Um, and most published studies address exotropia. So there is still a lot of work to be done to prove plication efficacy, but so far the information we have, the data we have is reassuring. So there was a very large systematic review, a meta-analysis of horizontal plications and in 2020. And they found that there was no difference in the success rate between plications and resections. And this is the largest meta-analysis that's been published. There was a lot of heterogeneity. So in some surgeons' hands, plications worked much better than others. And overall, the success rate was surprisingly low. But there was no difference between plications and resections. And there was no statistical difference in the mean amount of the deviation corrected. There was no statistical difference in patients who were undercorrected after surgery. There was no difference in outcomes between exotropia and esotropia. But as we mentioned, there are not a lot of randomized controlled trials or long-term data, which we still need. And the meta-analysis did have adults and children, and there was no difference in outcome by age. So there isn't an age that's too young for a plication, and there isn't an age that's too old for a plication. Do plications last? So as far as we know, the answer is yes. It's still a relatively new procedure in the United States. It was reintroduced in 2010. And so most of the literature available to me in the US is still, relatively new, under 15 years old. But Dr. Joe Deemer in Los Angeles was an early adopter of plications. He started doing them in 2012 and did a large review of his plications over 8 years. He compared them to his previous resections, 8 years of data, and found that over those 8 years long term, there was no difference in the outcomes, who needed additional surgery, who did not, who had successful correction. There was no difference between plications and resections. How many millimeters do I plicate? That's another very popular question. Some studies and some of our colleagues will advocate doing more millimeters in your plication than you would for a resection, typically about a 0.5 millimeter more per muscle. I personally do not. I use the regular surgical dose table for resection and do that with a plication. That's what Joe Deemer does in Los Angeles. That's what Ken Wright does. There are studies to support either approach. There are studies that show that maybe you should put a few more millimeter, a 0.5 millimeter more for each muscle. There are some studies that show that you don't need to. I think that each surgeon is going to have to do their own evaluation of their own data. So you're going to have to do a couple of plications and see if you have a trend of over or under correction. But in my hands, I do not get under correction when I use the typical surgical dose table. So I just treat these resections like they're plications and proceed. So another poll question. After plication, how long is the physical bump of muscle, that bulge underneath the conjunctiva? How long is that visible to the naked eye? About 6 to 8 months, about 6 to 8 days, about 6 to 8 weeks, or the bump never goes away. Okay, so 61% of you said about 6 to 8 weeks, and that is correct. Patients have no problem, in my experience, no problem tolerating the bump as long as they're prepared for it. If they don't expect that bulge, they get really concerned about it and track it very carefully. If I tell them ahead of time, you're going to have a big bump, your eye's going to be super red, that's normal, then they can handle it. It's not painful. And they've been reassured it will go away. So this is one of my recent patients. She had a lateral rectus plication, and when she just looks straight ahead, you really can't see much, but there is a bulge there after 5 days. A different patient who had a medial rectus plication. This is after a month, and you really can't see too much. It's red. Yeah, there's a little bump, but it's going to flatten really nicely. The muscle, the redundant muscle does atrophy over time. So let's apply what we've discussed to some case presentations. These are 2 patients that I have recently cared for. One is an adult and one is a child. So the first case is a 26-year-old male. He has a history of bony dysplasia and had orbit surgery to his right orbit. He had an exotropia before the orbit surgery. We had hoped orbit surgery would correct the strabismus, but it didn't. And he ended up with an intermittent exotropia of 20, a right hypotropia of 10 that was also intermittent and pretty well controlled a lot of the time. He had a convergence insufficiency with more exotropia at near. He had full stereopsis, no torsion. He often has good control, but late in the day, he got diplopia, and he works at a computer. So the last few hours of his workday were very difficult for him because he had diplopia. His near and distance deviation did not equalize after a 30-minute patch test. This is an important detail. So I covered his left eye or his right eye for 30 minutes, and then immediately on uncovering, repeated my alternate cover test to see if the distance deviation of 20 would grow to match that 30 at near after that 30-minute occlusion test. If it did, I could operate on 30 prism diopters of exotropia, but it didn't. So I can't operate for this full 30 at near because I could end up giving him an esotropia in the distance, and that would be worse than what he's experiencing now. So I decided to operate for his exotropia of 20 and his hypotropia on the right. And normally it's his right eye that goes out. He's nervous about bilateral surgery. It made the decision easy that we're going to proceed with lateral rectus recession, medial rectus plication with vertical transposition of those horizontal rectus muscles. How much? So I went to the table from the textbook that I usually use, and I looked at monocular surgery tables and exotropia, and I circled the 20 prism diopters, lateral rectus recession, and then medial rectus plication. Post-op week 1, he had a small exophoria that interestingly was pretty close to even in the distance and at near. His vertical was gone after the half tendon width transposition of both muscles. He was comfortable. His eyes red, but he's comfortable. And his diplopia later in the day, even after a week, has already resolved. Case 2. We have a 4-year-old. She has an alternating exotropia in the distance and at near. It is intermittent, but it's manifest most of the time. Her angle is 30 to 40 prism diopters with alternate cover. Her parents prefer a unilateral procedure. And even though her right eye is out in this photograph, typically it's the left eye that manifests. And she had mild amblyopia on the left, 20/30 rather than 20/20. We're still in the middle of patching, but they wanted to proceed with surgery. And so I, again, looked at the table for monocular surgery for exotropia. And I'm going to do a lateral rectus recession and a medial rectus plication. And before I tell you the outcomes, I want to just pause for our last poll question. What surgery would you perform? You know what I did. I'm curious what all of you would do. Bilateral lateral rectus recession, bilateral medial rectus resection, bilateral medial rectus plication, or unilateral lateral rectus recession and medial rectus plication. Okay, so I have some believers in the crowd. So many of you, 66% are joining me with unilateral surgery. 11% would go with a medial rectus plication bilaterally as well. So I did a lateral rectus recession of 7.5 millimeters for her 40 prism diopters. She was 35 to 40 prism diopters. And then I did a medial rectus plication of 5.5 millimeters for 35 prism diopters. Sometimes I do that. I'll take one measurement from one line and one from the other if patients really seem to vary a lot and I'm concerned about over-correcting them. And 1 week later, she had a small esotropia, exactly what we want. And then post-op month 2, she was orthophoric. And so that's the conclusion of the presentation I've prepared. I'm looking forward to answering questions in a moment. I just wanted to pause and thank you all. It's been a real honor to give this lecture today. I think I mentioned it's my first CyberSight lecture ever. This is my Gmail address. I would love to hear how your plication surgeries go or talk about planning. Feel free to reach out. The audience today has had registered attendees from 87 different countries. Actually, I think it's more than 87 because this list is everyone who is registered Monday morning. And I think a lot of people registered since Monday morning. But I wanted to recognize all of the different places that we're gathering from. It's an honor to be a part of this global community. So now I am going to look at your questions. Okay, so a lot of these questions are great. We went over many of them during the discussion. Are muscle plication and muscle tuck interchangeable? I briefly touched on that. I don't think they are. I don't think there's enough data yet to support that a tuck for a rectus muscle will work as well as a plication. For a superior oblique, different story. But for a rectus muscle, I would advocate plication is equal to resection, but not tuck. And tuck would be muscle to muscle. Plication would be muscle to sclera. Can you do a resection and a plication on a blind eye to maximize the resection? Um, I've never done that. And I think doing the resection would kind of it would it would undo your advantage of preserving the ciliary arteries. A blind eye that's at risk for ptysis is a great eye to do a plication on, because you're preserving that circulation in an eye that is at risk for ischemia. I would just do a maximal plication and see where you land. And then, so we talked about my preferred suturing technique. Thank you. These questions are great. There are many. So do I have any adjustment to the, oh yeah, we talked about whether or not I changed the surgical dose table. I don't. Some people, for how many millimeters to do the plication instead of the resection, will add a 0.5 millimeter to each muscle. Which suture is better? I use 6-0 Vicryl. You can use 5-0 Vicryl or any dissolvable suture. I don't think you need the 5-0. It's thicker. It'll cause more inflammation as patients are recovering, and more redness and itchiness if they have a reaction. I would use a 6-0 if you have access to a 6-0 dissolvable suture. It's plenty strong. Most importantly, to use a spatulated needle. So in my videos today, you are seeing an S14 needle. I know a lot of our colleagues prefer the S29 needle. I think they're both good. S29 cuts a little bit better, but I work with residents on many of my cases, so I prefer the S14. I think it's a little bit easier to handle if you're inexperienced. How long is the procedure reversible? So we talked about that. To be safe, I'd say 3 days, but sometimes a week. Can you plicate again after you've undone a plication? Yes, you definitely can. You can plicate again. You're going to have to judge the tissue on the day that you undo the plication to see if it really can take another procedure. It might be swollen. You don't want to encourage too much bleeding or scarring or swelling. You may need to undo it, let the patient heal, and try a plication again another time. If you're still, in operating room conditions and the tissue doesn't look friable or swollen, you probably could change it the same day, but you'll still need to cut all of that Vicryl out and place it fresh, because you won't have your needles anymore, unless you've placed it on adjustable. And then let's see. We talked about the cosmetic concern for the bulge or the lump. I, in 5 years, have had one patient who was really upset about the bump. And I talked her through it. I constantly reassured her that it was getting smaller. I took serial photos for her every week to show her it was getting smaller. She just needed a lot of reassurance. And then, one day she was happy. It took about 2 months. I do plications in lieu of resections for all of my patients, except the one patient with a muscle dystrophy where I had to do a biopsy of his muscle in the last 5 years. Do I recommend mini plication for rectus muscles? In full transparency, I actually have never done a mini plication. But it was a part of my learning and preparing for this lecture, and I do intend to try it. For small deviations like 9 prism diopters or less, I think it's a great option if you're in the operating room anyway, or you want to try and do it under local in the office. For small deviations, I sometimes also will rely on Botox and bupivacaine injections. But this is another great tool when you're trying to just do some finishing touches on a surgery that was mostly successful, but they have a small residual deviation, or they have a small deviation to begin with, but a lot of symptoms. So does the folded muscle increase the risk of Dellen? Yeah, it can temporarily increase the risk of Dellen. Usually that resolves pretty quickly. It doesn't take 6 to 8 weeks for Dellen to resolve, but yes, you can temporarily in the first week or two find that vision is down from Dellen. And again, if you just prepare patients for that, it's going to be swollen. Your vision might be a little blurry. You might find that you're tearing a lot. Usually they tolerate it, in my experience. Would I prefer limbal incisions to allow some conjunctival resection? That's an interesting question. I don't. I do fornix incisions whenever possible. And in older patients, when I'm concerned that the fornix incision will tear, or in a patient like who's had radiation and I'm concerned that the conjunctiva is too friable for a fornix incision, then I'll do a modified swan where I start a fornix incision and then extend it anterior to the insertion. I really like sparing as many vessels as possible, and I don't think that I've ever found a clinical benefit from conjunctival resection. I try actually to keep the conjunctiva loose, because in my hands, it's the muscle surgery that gives me control of my patient outcomes, and adding in a conjunctival resection, I think, would make it more unpredictable for me. How about, let's see. How about sliding shape extraocular muscle transposition with plication? So I think you mean if you're doing an adjustable, can you also adjust the transposition? Like if you're doing a vertical transposition, you can. You have to adjust the muscle plication and the transposition simultaneously. So basically you can transpose the muscle as many millimeters as you're plicating. So if you plicate 5 millimeters, you can transpose up to 5 millimeters. And then you can adjust that on an adjustable technique. And then there was a question, I did a tendon transposition with plication. Who did I do it on? It was an adult who had a small vertical as well. So while I was correcting the horizontal strabismus, I did also half tendon with vertical transpositions. What about V pattern or A pattern? Yeah, you can do plications with V patterns and A patterns. You would move the muscles in the direction that you would move them if you were recessing or recessing and resecting. It would be the same direction to correct the V and the A pattern. It's just that instead of resecting the muscle and physically moving it up or moving it down, you're just plicating it. You're putting your suture in the muscle and just moving it to the insertion point that you want on the sclera. Follow the spiral of Talot. And there will be kind of a a sideways fold, oblique fold to the muscle when you plicate, but that's okay. It's stable. So what type of suture? So we talked about this already. I think I answered your question, but I would just use anything that dissolves after a couple of months. We want the tension to be maintained for a couple of months, which is why I use Vicryl. I wouldn't use like plain gut. If you don't have access to something like that, then you could use permanent suture. And just if the patient has a reaction later, you can always just remove the suture after a couple of months of healing. So can I please repeat the steps of suturing for plication? Yeah, so what you do is, so this is my little model here. So I don't know if you mean suturing the muscle or suturing the sclera, but in the Ken Wright technique, the first one I showed you, you do your partial thickness, center to edge, and then a locking bite, avoiding the vessels. And then you do the same thing on the other side, partial thickness and a locking bite, avoiding the vessels. For the Monte del Monte technique, which I like, it's new to me, but I thought it was really great and the outcome was great. You start the same, you go partial thickness through the muscles, center to edge, but then you double back and you go edge to center through the same holes. And it's partial thickness, but it's more superficial. You're going really like just skimming the superficial layer underneath the ciliary arteries. And you're doing that to set yourself up to do a full thickness through that original hole again. So then you turn your needle around, you go through the original hole, and your needle comes out underneath the muscle full thickness. You'll have a loop here that you'll pull it through to lock it. And you just kind of pull back on your suture and then pull forward so you don't get an air knot. Then you go in the other direction, partial thickness, center to edge, back through the same hole, very superficial, just underneath the vessels, edge to center hole, and then your full thickness. You leave a little loop here like this, and then you do full thickness through your original hole, down below, and you pull it through the loop to lock it. Then for your sclera, if that's what you were asking, you can do cross swords in the center, partial thickness scleral tunnels, or you can do partial thickness without doing cross swords, but you have to be careful to avoid the vessels. So you would like go in here and make sure you come out like over here. And then to tie the muscle, you pull, I hope this is answering your question. You pull the Vicryl up towards the ceiling. This is the only time in strabismus surgery we're pulling suture up to the ceiling. Normally that is unnecessary tension and you're going to break your suture and you're going to lose your muscle and everybody's going to be unhappy. But for plication, you do have to gently pull up away from the eye towards the ceiling. Then you pull towards the limbus, parallel, much like you're used to. Normally, when you recess or resect a muscle, you're pulling in the plane towards the limbus. But for plication, it's up, then towards the limbus, up towards the limbus, once or twice, sometimes even 3 times, depending on how much the muscle is willing to move to get it to lay flat. And then you finish laying your knots. Okay. Mode of anesthesia. The mode of anesthesia for this procedure is up to you. It's really the same as what you would do for a resection or a recession. So I favor general anesthesia, but I have done these procedures under local anesthesia. I had an adult patient. I wouldn't do local anesthesia for a child, but I had an adult patient with multiple medical issues who was not comfortable having general anesthesia. And I put, I think 5 or 6 cc's of Marcaine subtenons through my fornix incision. and let that sit for a few minutes. And then she was totally comfortable during the plication. I put some tetracaine on her cornea before I made the conjunctival incision. She did great. Possible complications in plication are similar to other complications with strabismus surgery. You're reducing the risk of anterior segment ischemia. You're not completely eliminating it. So it's still a risk that you have to discuss with your patients ahead of time, but you are significantly reducing that risk. Risk of infection, inflammation, bleeding, scarring, diplopia in the opposite direction from overcorrection, all of those things are unchanged risk, the same as other strabismus procedures. Okay. Do I feel comfortable operating on 3 muscles at once when I do a plication for one of them? Yes, I do. I don't typically interrupt 2 ciliary arteries at the same time. Like I'm trying to think of a situation where I'd be doing 2 recessions and a plication. That's pretty rare, but I would. Um, yes, when I do transpositions, like for 6 nerve palsy, I also use a vessel sparing procedure. So I tend to favor sparing vessels whenever possible. But yes, if you're only interrupting 2 muscle circulations, then yes, I would do a plication as a 3rd procedure at the same time. And then I have time for one more question. I'm sorry, these are great questions. I'd love to be able to get to them all. So what is the maximum millimeter I can plicate? So that's a great question. And I think it depends on the surgeon and the patient and the orbit and how far back you can get. When I do, again, surgery for 6 nerve palsies, I plicate the lateral rectus muscle maximum and do a modified Nishida procedure, transposition to the 6th. And then I recess usually the contralateral medial rectus, sometimes the medial rectus on the same eye. How much do I plicate the lateral? I just do maximum, like whatever I can get. So in most patients, it's really hard to get more than like 7 or 8 millimeters to plicate and fold nicely for you. But if you feel like you can get far back, and I mean, don't forget, you also don't want to get the inferior oblique involved when you start getting too far back on the lateral rectus. But you know, I think you can get as much as you feel comfortable being able to fold smoothly and being able to see the vessels well where you're placing your needle, that you'll have control sewing the muscle that far back in the orbit. You know, you want to be careful about that. I said only one more question, but I just want to scroll through quickly. There's no minimum age. I think any age is okay. And I don't think kids rub their eyes more because of the lump. I think that I actually think kids do better with plications because their eyes don't hurt. And so they're willing to move their eyes in full adductions pretty much right away after surgery with plications. And how I manage pain during adjustables, I use topical lidocaine jelly. It's a 2% formulation. I put tetracaine or proparacaine on first. I clean the area and then I put sterile lidocaine jelly on. And I make sure to set a timer and like leave it there for 5 minutes before I start poking the eye. Okay. I think that's most of the questions. And it's been a real pleasure. Thank you very much.